So, we are privileged to have Dr. Bansi Saboo with us today. He is going to talk about a very important topic about initiation of insulin, the inertia that we have, the fear that is there in our mind. Forget patience comes later. So, Dr. Bansi Saboo will talk about this. Welcome, Dr. Saboo. All yours now.
Yes. So let me start by thanking Dr. Vachhajani and Family Physician Federation of India. But I think we are sitting here with more than 90 minutes, and as previous speaker talked very nicely, that more than 90 minutes sitting is as dangerous as smoking. So it's a time for stretchability, and let us get up and give a good stretchability to your body. That's the best thing which you can do. Thank you. The next thing which he told is that if you have an issue of sleep, I give you full liberty for next 15 minutes for nap also. So just don't worry, you can have a good sleep too. So the point which he made very clear that a diet which is very important, and it's a major reason for many of us also to have diabetes, and many of our patients who have also diabetes. But one thing what we have noticed in last 25 years of our practice, when I was a medical student or a registrar in a medical school, when we were running the diabetes clinic with only 3 medications which was available, insulin, sulfonylurea and metformin, our 80% of the patients were not able to get control. And the situation is not changed in last 25 years, with hundreds of medication with their combination, with a lot of data which has been published in our country and all over the world, but still our 2/3 of our diabetic patients are not controlled. So I think somewhere we are missing the link. And I am not very big expert of internal medicine, as when I was a student of internal medicine, even I scored high, I could get some medal also. But then I realized to do so much internal medicine, I picked up only one subject, and it was much easier for me, and it was only diabetes. And while practicing, what I found that any one of you might be practicing anything, you will find 30% of your patients are diabetes. So when I started, it was 5%, and today almost 1/3 of your patients will be diabetes. So I mean, each and every family physician, or whether you are a consultant of a gynec branch or orthopedic branch, still you have to know more about the diabetes. What challenge which we have is insulinization. It's an inertia. It's a big inertia. And let me tell you, this inertia is not with the patients only. Even if someone is a doctor also become the patient, he also have the similar inertia. I always ask my patients that what's the purpose of treatment, When you have a patient in front of you, I think one thing which we should ask the patient, the caregiver and yourself both, all 3 of you, that what's the purpose of treatment? It's a good quality of life, the happiness which we want to give to the family, we want to give to the patient. And that question we should ask constantly. I mean, are we doing good for the patient? Are we doing good for the family? Or is it going to improve the quality of life for the patient? That's the only question you should have in your mind, whether you are treating your own brother or you are treating whoever of the city of your patient, or someone who might be your, someone who is who of your city also. What I am going to talk is delaying insulinization in our country, and it's not only in our country, it's all over the world. The UK, there is a National Health Service, and primarily all patients are treated by a primary care physicians. That's what type 2 diabetic patients. All patients who are type 1, all who develop complications, all who have some special issue, then they have to go to the hospital to see their diabetes department. So I mean, the diabetes, type 2 diabetes is a disease of a primary care physician. I mean, primary care physician, maybe a family physician, maybe MD medicine person also. It's a disease where he is your first point of contact, and that's what the disease is with primary care physician. There are a lot of hurdles to start insulin therapy. Diabetes prevalence is increasing all over the world. This is International Diabetic Federation data. I'm not talking more about it. Can I have this mic also so I can talk while talking also? But this data from India, the ICMR data, in-diab study, it is the national study of diabetes, which is one of the biggest epidemiological study in our country. It's not working, I don't know. Yes, I think it will work. Yes. It's one of the biggest funded study from our country. I was the chief investigator from Gujarat, and what we found that in India we have around 101 million people with diabetes. This is in 2023 we published this data. And what we have at present 236 million persons with dysglycemia. It means adult population. This is I'm talking of above the age of 18, and most of us are above the age of 45 or 50. If I say it's 50, probably we have 50% of us are either diabetes or impaired glucose tolerance. We will have in our lifetime dysglycemia, maybe 2/3 of us. Even for a mildest stress, for any hospitalization, we will have dysglycemia. And this is the data. Many of us will not have the diagnosis itself, but this is what the data which we have in our country. At present, only 1/3 of them are treated by insulin. They are given insulin after 10, 15 years of diabetes. Even a doctor, when they say that, yes, you need insulin, the first answer is denial. They don't want to take it. And the same is with 46% of the patients who are uncontrolled, they don't want to take it. Now, I always say, why patient is not taking the insulin? I think he sees the face of a doctor. How confidently you are saying him whether you have to take or not to take. I am sure I was listening sir lecture in first talk. Then when sir says that you have to go to the other doctor or you have to go and get admitted in the other hospital, patient will not say no because you are saying him very confidently. So it's the patient who sees how confidently you are saying. Patient does not know. The doctor was showing hyperacute MI. You all were diagnosing that this is the acute myocardial infarction. And I'm sure if you see that ECG, you will say confidently that patient that you get admitted. Patient is saying, no, I can't because I have a family function. I have a marriage in the family. Someone is not well or I came all alone. Nobody is there in the family to take care of me in hospital. But still patient get admitted because you are telling him with a confidence. Well, that does not happen when we are talking about the insulin therapy. We say, okay, you take it, then say, no, I don't want to take. Okay, let me try some other medication. And that sort of an answer will not allow your patient to take insulin injection. This is, let me talk about the patients. It's a simple, a garden variety of patient. Any patient who is coming to you with a triple drug oral anti-diabetic therapy, maybe 3, maybe 4, maybe some of these patients are on 5. But if an uncontrolled diabetes with a patient HbA1c of more than 8 or 8.5, probably he becomes the right candidate to start with insulin therapy. Nothing works. This is one very important slide which I want to give you. Suppose some patients say that let me try the 3rd drug, let me try the 4th one, let me try the 5th one. The problem is in India we don't have the data of our own to publish it again. But this you see, if you have already a patient who is on 2 drugs, if you add the 3rd one, it is not going to decrease significantly HbA1c. It's hardly 0.5. If you add the 4th one, rather than increasing, sometime it increased the HbA1c. There will not be any benefit in next 3 months because patient was having already 9 HbA1c. You added one more, it may increase the HbA1c, it may not have any benefit to that particular patient. So this is the only way at that point of time you have to add the insulin. So this is very confusing sometimes. A patient wants to add one more drug. The doctor is also equally interested sometimes because who will spend so much time? Patient is interested to understand the insulin therapy, but because we don't have the time, that's again a challenge for our patients not to start. We all know about the complication. I need not to talk about all these complications because diabetes is a disease which you must have heard 100 times and 1,000 times, but we all know that it increases the complication in diabetic patients. But delaying intervention, if you are delaying something for anything, you know, even the justice when it is delayed, it means justice is not done, right? The same thing, anything which is delaying, it means that treatment is not done. If some patient comes with a acute MI, you have to treat it with that window period. There is no point of treating the patients after 3 days with the same therapy, thrombolytic therapy. It is not going to give any benefit to the patient. The same way, if you are not treating the patient at right point of time, the time period which he has not given the insulin injection or he has not been controlled for those 6 years, 8 years, going to increase the risk of complication in that particular patient. And that's very important. These are the therapeutic inertia. I am sure that we all have inertia. As I told you, even if we have the disease also, we also have the inertia. It's a distress which leads to, sometimes what happens, the first thing when someone is diagnosed, even with hypertension, diabetes, even for any disease, the first thing he comes with a distress. He feels that I should not have. Even many of us might have get admitted in hospital also for anything. The first thing which we feel that it should not have come to me, why I am getting it, and same type of feeling patient is also going to have. And that leads to inertia for him. The inertia is definitely with the physician related. What you can improve is the physician related inertia. It is we who are responsible for not giving, and there are hurdles. So my talk is how to make you more confident while writing insulin therapy. That's what the topic which is very important for us to have. Now the concern which we have, it may be hypoglycemia, but before that, many of us have already in our mind that patient will not accept it. And that is the reason you don't tell the patient with that much confidence. The conviction power will be only there once you are convinced yourself. If you are not convinced for that, you will not able to have a conviction power for patient also. The weight gain, hypoglycemia, and a poor quality of life. Sometimes patient says, who will give it? I don't have any family member who can give me, or I have to travel a lot of time and insulin to take along with me will be a real difficult. These are all logistic questions, and all logistic questions have an answer. It means these logistic questions cannot be only for you. There are many hundreds and thousands and millions of people around the world who have similar problems also. So you should have the solution for those questions too. These are the physician barrier too. The Dawn study results had shown that insulin therapy is delayed just because they feel when it is absolutely necessary at that time they want to give. Because people want to please the patient. We just want to give the medication which helps patient know. We want to please sometime. Suppose patient is saying that 5 દિવસની દવાની જગ્યાએ 3 દિવસ લખે હા સારું 3 દિવસ પછી જોઈ લઈશું આપણે જોઈશું. So we are not here to please the patient. We are here to take care of the patient. For the health, for the happiness, we are here to give him a good quality of life. That should be our complete purpose of that. The physician barrier are there. Healthcare professionals are discouraged from initiating and intensifying therapy despite the poor control which they have. The suboptimal knowledge of the guidelines, difference between guidelines recommendation, changing targets and newer therapies, they all are the issues with many of us because we don't want to sometimes stick with the newer guidelines too. The time and manpower, I think, is the biggest challenge. If you don't have a dedicated person with you who can teach, educate, or you don't have that much time, you would not like to put him on any newer therapy. And this is the reason sometimes we don't improve in our practice. Science is a constantly changing and we have to improve over a period of time. I always say, we physician mean we are non-intervention specialists. I mean, someone may be a family physician, maybe a consultant physician, a diabetologist. We are actually poor as far as a new therapy is concerned to adopt it. Have you seen now today any surgeon who is saying that I don't do the laparoscopy? Because if you know that, if he is not going to do the laparoscopy cholecystectomy, a patient is not going to go and get open cholecystectomy. Am I right? So he has to go and learn that surgery. If someone is like an orthopedic surgeon, he has to go and learn that new technique. Otherwise, he will be out of the business. But that we don't do it. We feel that yes, हमारा काम तो चल रहा है ना, why to do all this nonsense and let us do the same thing. So that's the reason we are not improving over a period of time. We are not adopting the new science and new technology in our field. And this is what every non-intervention, even for our interventional colleagues, if suppose somebody is gastroenterologist, even when he have done DM gastro before 50 years or 40 years, 30 years, there was hardly any intervention. But they learned. They learn to do the endoscopy because otherwise they will not survive. They learn to do ERCP. When ERCP was not there in institute, they learn. They learn to do the angioplasty. They have to learn, otherwise they will be out of the business. But we could not accept or we could not take it very positively for that. The physician education and training is very much required. As I told you in last 25 years, with hundreds and thousands of CME you must be attending, and me also we are doing, but at the same time still we are not able to convince our patients, and our patients are still remaining with the HbA1c of more than 2/3. We talk about the stroke, we talk about the heart attack, we talk about many things, but the primary reason for that is this. Sometimes I feel so pity. A patient goes to a retina specialist regularly, paying him for 2 lakhs, 3 lakhs, 5 lakhs rupees, and not understanding the importance of a tight glycemic control. And that was the reason for him to develop all this, all this retina issue. He is not able to understand that problem is there. He is going continuously, regularly for a nephrologist for his renal failure, but he could not understand in last 20 years, he has not done. And what he could have done today, suppose you ask him, "Ave to tamari kidney fail thi gayi, ave tame shu kari sako?" Yes, we can teach him one more thing. Now you tell your daughter, your son, your brother, if they have diabetes, keep their tight control. If they don't have diabetes, check them, get them screened. Get them here in my clinic. I will teach them how intensively we have to control. If they don't have, let us talk about the prevention of diabetes. So we have a lot of scope. As a family physician, it's not like that you don't have the practice. You have one patient, try to find out how 10 persons in the family. Not as a patient. We are not here to get more patients, but we are here to educate them. And we will get our business more running and running also. We have to educate, we have to teach them that yes, they don't have diabetes, let us try that they should not have diabetes in their lifetime. If they have diabetes, let us try early and aggressive control for them. If your father have developed a kidney failure, at least you should not develop kidney failure in your lifetime. That should be your message. That's what we should do trially. The solutions are definitely newer insulin are less hypoglycemic. There are hurdles from the patient side also. These are known as psychological insulin resistance. We know that insulin resistance is a concept, so we had put a new term for psychological because patient does not want to take the insulin. PIR is very, very common. If you just ask your patient, many of them, they will say they don't want to take it, but once they will take it, they will have a better control. Once they will have better control, they will have better quality of life, and then they will follow you more regularly. It is ultimately a doctor prescription at that point of time will not sufficiently satisfy patient. At that time, patient may be happy because you have agreed with the treatment which he had given, but patient will be at the end, after few months, he will show only once the patient is very well controlled. These are some of the actions with insulin use behavior. These are the points which I just wanted to talk. The 3 key HCP action to facilitate insulin initiation were identified, helpful, were associated with more successful initiation and persistence, but I will not go with the details of all these things because point is, taking insulin makes it more difficult to fulfill my responsibility at work and home, and this is very commonly question which is asked by the patients. I am afraid of injecting myself. You can always teach the patient at the time of inside the clinic itself. Injecting insulin is painful. Now it is no more. With the 31 goes insulin needle which we are using, it's hardly any painful. How many of you have checked? You are not diabetic, not taking insulin. Have you tried insulin injection? Just try it. It is not painful. It's not painful. Once you will try, then you will able to convince your patient more. I had used in 25 years multiple times just to tease the patient in front of that I have taken. See, there is no pain. So, take it. And just give the patient example that there is no pain. Patient will be more confident if you do it yourself. Elevate the fear of hypoglycemia with the newer insulin, with the longer acting insulin. There is no hypoglycemia. There is a weight gain which is minimal because a weight gain is a control, or it can be controlled with a good control of sugar. There will be some weight gain, but now we have medication which can be done. Taking insulin means it is more flexible or less flexible. Because of the newer insulin, you can make flexible in the life. Like giving him a longer acting. A patient can take a Tresiba injection in afternoon and sometime even in evening time also. If he does not want to have, because ultra long acting insulin can be given also. And sometime before, maybe in another 3 months or 6 months when I will be talking, I will be giving once in a week. Icodec is coming. We will be giving only once in a week basal insulin. A time will come, a designer insulin will come when every day you have to take one shot and everything is fine for that also. There are stigmas for that, but patient does not want to take. Now, biggest stigma I have seen with the doctors. With so many meetings where we go, I am sure that
30-40% of them are diabetic. Out of them, you know that 1/3 of them has to be on insulin. So it means if I am seeing 200 people, there may be 50-60% must be diabetic, and out of them 5-6 must be taking insulin. Basal bolus. But I have never seen someone as a doctor who is taking lunch in a conference and taking insulin in front of everyone. I mean, that's sort of a stigma which we have. So why you have that stigma is there. Lipohypertrophy, if you know that it is a condition because constantly taking at the same place will lead to this problem. It's not the muscle which get increased, but it causes a lot of hypoglycemia and hyperglycemia too. There is a solution summarized to it's time to breathe insulin inertia. And I need not to talk more about it, but the only thing is convince yourself and then do convince your patient. For everything. It's not for the insulin therapy. Whether you are writing a person for a vaccine, first you have to get convinced yourself. If you will be convinced, then and then you will able to give the patient injection. If you are not taking the Shingrix injection for yourself, for your family, you will not able to give that herpes vaccine to your patient also. Because unless we are convinced, you will never able to convince your patients too. So for each and everything, whatever we are doing, and one thing we should always keep in our mind that we are doing good for our patient. That's the only purpose. Ethically, legally, by all means, we want to give him a good quality of life, and that we should have a question while treating the patient that what is your aim of the treatment?
Sir.
Will it give the treatment better or not?
Sir,
With this,
please.
thank you very much once again. I invite you